But like, you know, the whole idea was really just to talk about home birth and the safety of home birth and your thoughts on it. Actually, you know, you've both come along, and I think it's just another one of those options that are out there. And I don't know where you're sitting or what your thoughts are on it, but and this is not in any way to convince you that it's the right way either. It's just about exploring another option and seeing what it's like, especially because of the conversation that we had the other day, where I was talking about the birth center that I worked at in Rondebosch, and that's actually a very similar setup. And Cassandra, your question was, yeah, but what happens if you need a cesarean? And
Yes.
it's the same question that you ask if you are thinking of having a home birth. So I have prepared a few things to go through with you, but I was wondering if you perhaps wanted to start off by sharing with me your main questions. I mean, they're probably going to be the ones I'm going to answer, but when you think about home birth, what is it for you that comes up that either makes you want to have it or not want to have it, or makes you afraid of it?
For me, it's just if there's complications, that's why I'd be afraid of it. If something comes up that hasn't come up during the pregnancy, and then I'd have to find a hospital to then have a procedure done. Yeah, that would be the only downfall for me.
Is there anything about having a home birth that is quite appealing to you?
When you say home birth, I'm thinking more of the birth center. I don't think I'd be comfortable at home, but I think I'd be comfortable in a birth center.
Okay.
Just with the more relaxed feeling than a hospital feel.
And for you, Cara?
Yeah, I'm definitely with Cassandra on the last point, with being in a different environment that is more relaxed than being in a hospital. I find that's huge because I think it's less stress. Again, complications. Yeah, I'm also thinking if you do need anything, I'm relatively close. Sorry, I'm sort of my phone off. I'm relatively close to a hospital. So for me, I don't feel too bad if I had to birth at home and I could still get there. I'm like 8 minutes away. So I think it could work. And cleanliness, that's a thing as well for home birth. That worries me.
Okay.
And noise. What if I make too much noise? You know, my neighbors hear me. The thing that I do like about the home birth is the togetherness, and that sort of, you'll never get that feeling again sort of thing. In a good way, I'm saying, like, it's a once off moment. And I find that very appealing because I find that's bonding and something really special. But I feel at a birth center, you could also get that. I just don't see, I know that Alnisa one now that you shared, I had a look on the site the other day and your video. Yes, and I know there's one called Lila that has moved to Vincent Pallotti. But that's just hella far. It's like 30 minutes, 40 minutes from.
Where are you?
Parkland side.
Okay, well, let's start off with the complications, because I think that is the first thing that comes up generally, and it applies to both home birth and a birth center. As I explained, in a birth center, it's run by the midwife, so there's no doctor present on site, just as there wouldn't be a doctor present on site when I do a home birth. Now, it's immediately kind of like a little bit of a worry, because as you say, the first thing is, what if there are any complications? But remember that there are certain criteria that we have for both a home birth and a birth center. And I actually made a little slide so that you can look at them as I talk through them. And one would be that it's generally, if you're only having one baby, so most midwives and birth centers would see a twin birth or a triplet birth or multiple birth as a risk factor that they wouldn't take on, because so you want to be close. If you have a single baby, then that would be low risk. We want to know that your baby is in a head down or cephalic position, so not in a breech position. And that one is a little bit variable. Okay, so there are some midwives who would consider doing a breech baby at home. And that really does depend on their level of skill and everything, but I don't think that's the case for either of you, so we won't go into that in too much detail. The other thing is making sure throughout your pregnancy that there haven't been any risk factors that have come up. So the risk factors that we're looking for are any gestational diabetes, and that's the reason that we check your urine at every visit. And what we're looking for when we check your urine is that there is no glucose in the urine, because if there's any glucose in the urine, that might be an indication of one, your kidneys are working harder and differently, and the hormones of pregnancy affect them. But if we notice that several times, then we are going to check your blood for excessive blood sugar and see if there's any gestational diabetes developing. And gestational diabetes is exactly that. It's diabetes that only develops during pregnancy, and usually when your pregnancy ends, then so does the diabetes. But that would it would be a risk factor that we wouldn't consider. One, because of the diabetes, and two, and it would depend on how well controlled it is, but still, sometimes babies of moms who have diabetes are much bigger, and we would be more concerned about the size. Now, that's another conversation on its own, but still they are particularly big, and it just does add to that. The other one we'd be looking for is any preeclampsia or high blood pressure. Now, that's something that we watch throughout your pregnancy, because preeclampsia can develop in any stage of your pregnancy, but it usually starts in second trimester, and it will either start like quite slowly and gradually rise, where every time I see you, I notice that there is a little bit of a jump in your blood pressure. Anything over 15 milligrams of mercury, which is the measurement we use, would be a red flag for me. And we would either put you on medication, or depending on what stage of pregnancy you were at, we would refer you out, because then you would be seen as having preeclampsia. The other way that it sometimes occurs is that it's sudden onset in the last trimester. And that's, in that case also, it would happen where if it's sudden onset and it's significant, you would present with like headaches, blurry vision, and possibly even a pain that you get just under your breast and on the top of your belly. It's what we call epigastric pain, and it's a sharp and very noticeable pain, which, coupled with a headache and blurry vision, obviously you're going to come in. The first thing we would do would check your urine, and we would be looking in that case for protein. And then if we notice the presence of protein in your urine and a high raised blood pressure, then we treat you immediately with magnesium to bring the blood pressure down, along with some other drugs, and you would be immediately referred out, and we wouldn't consider a home birth or a birth center birth if there is any preeclampsia. So it's risk factors like that. The other thing we're looking at throughout your pregnancy, of course, is the growth of your baby and the health of your placenta and your weight gain and your overall health. So this is the reason why your antenatal appointments are so important, because every time we see you, we are making sure everything is staying within the parameters of normal. And if they're staying within the parameters of normal, then we are essentially ruling out the risk factors that we are looking for. So, you know, there are many women who get seen at Al-Nisa, because obviously Al-Nisa being a maternity unit or a birth center like that, the women are seen throughout their pregnancy at Al-Nisa. If I was doing a home birth and I take on a client, then I see her throughout her pregnancy, and that's my role, is to rule out those risk factors and to make sure that all her blood pressure and her urine and her blood tests, her weight gain, the baby's health are staying within the normal parameters. And the tools that we use during pregnancy for that are just your normal urine dipsticks. So like every time you come and you give me a urine sample, I stick a little stick in it, and that little stick tells me if there's excess of glucose, if there's any infection, or if there's any protein. I'll always check your blood pressure. I always use a tape measure, and I measure what is called the height of fundus. So I don't think when you're seeing an obstetrician, they tend to do that. They don't measure your height of fundus, and they don't do what we call a palpation, which is when I feel the position of the baby and the size of the baby. So it's a very hands-on midwifey thing that we do. And there's two things that we are looking for when we do that. One is just seeing what position the baby is in. If the baby is engaged, depending on in your third trimester, towards the end, I'm looking to see, one, if the baby is head down, and secondly, to see if it's starting to engage in the pelvis. The other thing I'm looking at is the position of the baby. Which side is the back lying? Is it on the left side? Is it on the right side? Is it slightly posterior? All of those things give me a very good indication of what is actually going on. And when I measure how the height of fundus, what I'm doing is I'm taking a tape measure literally from the top of my pubic bone. I put the tape measure there, and I draw it all the way up to the top of your belly. So I'll push my hand down to feel the top of the belly, and that measurement will usually correlate with the amount of weeks that you are. So if it's 24 centimeters, you're usually 24 weeks. If it's 28 centimeters, you're usually 28 weeks. And it's a beautiful way of gauging how your pregnancy is progressing. And it's the way that we used to work before we were doing the scans regularly. So these days, we get the same information from a scan, but they're doing it in a very different way. When we do an ultrasound, they are measuring the circumference of the baby's head, they're measuring the circumference of the baby's abdomen, the femur length, the crown rump length, meaning the top of the head, to the baby's bum. So all of those things are measurements that are used just in different ways. So for as long as you stay within the normal parameters, you are what we classify as a low risk pregnancy. And we expect things to continue that way as long as you got into labor spontaneously. So a home birth midwife will generally not do an induction. It's not within our scope of practice. And if you reach 40 weeks and you haven't gone into labor, then we would refer you to your backup doctor. In the case of Alnisa or the birth center, we work with the tertiary hospitals and the secondary hospitals. So, depending on what area you live in, but whatever, I would refer to the doctor at Grooterschuur or I'm not Grooterschuur, Mowbray. So if the woman gets to 40 weeks, she hasn't gone into labor, what we do, we're still very happy with her, but now her 41-week appointments will be booked for Mowbray. And at Mowbray, she will be assessed, and they will say whether or not she can deliver there or to come back to Alnisa, or if they want to there, depending on how things are. If she goes into labor between me seeing her at 40 weeks and her appointments at 41 weeks, she is able to come back to Alnisa. After 41 weeks, it depends on how that appointment goes. They might make another appointment for 42 weeks. And they say, if you go into labor before 42 weeks, you can either come, depending on what they find, you can go back to Alnisa or you need to come here. If at 42 weeks she hasn't given birth, then she will immediately go back to Mowbray, and they will probably consider an induction there. So as a home birth midwife, I don't do inductions. It's important for me that the mom goes into labor spontaneously. So given that already, I feel very confident when someone comes into labor. And if it's my client, I've got a very good relationship with her. I've seen her throughout her pregnancy. I know that everything is normal. And even when I work at Alnisa, although I only get to meet the woman when they come into labor, I don't do the clinic visits, I know the book and the record keeping system. So I can look back and I can see how many visits she's had, what was done at every visit. I can look at all the blood results and everything. And I know that if she's there, that she does fall into that category. So I expect her labor. I mean, if you're a low risk pregnancy, we expect your labor to continue, especially if you go into labor spontaneously, to continue normally and to stay within that normal parameter. So now woman's in labor, whether I'm at home or whether I'm in the birth center, I'll now move on to a different form of record keeping and a different things that I'm looking for now. But it's still about making sure that everything that happens in the labor stays within the parameters of what I consider normal. And it's important to note that when I'm working at Alnisa, and even when I do home birth, I'm following the government guidelines, which are actually quite different to the guidelines that are followed in the private hospital system. So one of them is that they are very happy for your early labor to go on for up to 24 hours, as long as everything is okay. Now, that would not normally happen in the private sector. And it's one of the things that I really encourage you to be mindful of and aware of, because what came out of last week's chat with Nicole was how your understanding of a natural birth was going into labor spontaneously. And that's a very, very good thing to take note of and to be mindful of. And the second thing is of allowing your labor to establish a rhythm and to get into active labor before going into hospital. Because very often, especially when it's your first baby and you are going into private hospital, and if you are feeling fearful, because you don't know what labor feels like, and you're not sure if it is labor or if it isn't, and you're still worried about everything going wrong or something going wrong, your tendency is to go into hospital because you think, well, that's the best place to be. You know, if I'm in labor, I need to be in hospital, and there they'll be monitoring me, and surely that's the right thing to do. But it isn't really always, and I can't say a blanket it isn't. Obviously, every situation is different, but I encourage you to stay at home for as long as you possibly can, because it really does take up to 24 hours for your body to warm up and get into that rhythm. And it's not that you're in hard, fast labor the way you see in the movies in those early stages. In fact, the first 6 or 8 or 10 hours, you're probably not even sure you are in labor. You're just like, I've had loads of Braxton Hicks today. They've definitely been a lot more regular. I'm a lot more aware of them. I went for a long walk on the beach and they carried on. I came home, I had a rest, I managed to sleep, but I woke up and I was still having them. It's now 6 o'clock in the evening, and that's been happening since 8. So you've already been in labor for 10 hours. Okay, fantastic. Not like actual labor, but things are warming up. It's like heating up. And I'd encourage you then to have a lovely dinner with your husband and to go to bed and sleep as much as you possibly can. If you can't sleep, well, then you probably are in labor, but try and get as much rest as you can until you really can't sleep, because then it is picking up. And then by that stage, you're thinking, right, this is now labor, and they are actually regular. And I'm having at least one every 5 minutes, and every single one is lasting at least 1 minute. And that would be the time that you would consider going to the birth unit or to the hospital, or if you were having a home birth, calling me. Okay, so it doesn't really matter where you're having your baby. You'd like to, that early labor is the time where you're kind of just chilling out and being in your home space for as long as possible. If you are having a home birth, at that stage, I would probably come over and I would spend some time with you and possibly do an internal examination, because an internal examination is a great way for me to assess your labor or how far you are, because I'm getting an indication of how open the cervix is. And at that stage, I would expect it to be open probably 4 or 5 centimeters. You know, you usually, by the time things are picking up and regular, you're almost halfway. And once I've ascertained that, I know that the most important thing now is keeping you in that lovely, calm, relaxed state, because now things are going to start becoming a lot more intense. You're going to need to use your breathing techniques, and your partner's going to be a lot more active in becoming aware and pacing you and guiding you. And if you were at home, I would allow you to find your way around. I would be there, and I would be coming and checking you every half an hour, listening to the baby's heart, checking your blood pressure, but more or less staying out of your way. If I was at Al Nisa, I would be doing the same thing. I would be encouraging you to be walking around, husband sitting there with you on the ball, bouncing. And if you needed a lot of hands-on assistance, then I would definitely be with you. But if you didn't, I would be giving you space. And I would expect that stage to go on for another 6 to possibly 8 hours, bearing in mind that because you're now in active labor, things are picking up and it's exponential. If you likened it to going on a very long hike, early labor would be the part where you know, walking through the meadows and it's all beautiful and your pack is light and you're having a little lunch and it's all flowers and rainbows. Active labor is when you hit the mountain and you start climbing. And it's a lot more difficult. Your pack becomes heavy. You don't want to eat anymore. You're dodging rocks and boulders, and you really have to be focused, and there's no turning back. All you're focused on now is the top of the mountain. So that is the time where, you know, your partner really has to step up as well. And that would also be the time where I am now a lot more alert and aware. And I'm looking, my main thing as a midwife, whether I'm in a home birth or a birth center, is making sure that in the next 6 to 8 hours, you stay within the normal parameter, which means that your contractions continue to be rhythmic and regular, that they get more intense and closer together as the time moves forward. So literally that climbing up the mountain is getting steeper and it's getting harder. So I'm watching you getting more and more focused and intense, and the only thing that matters is climbing that mountain. And the other things I'm looking at and watching for are, how is your baby managing with that? So I'm checking in on your baby's heart. How are you coping with it mentally, emotionally? How are you managing with the sensations? So do you need any outside assistance, whether that's medical pain medication or just hands-on massage, guidance with the breathing, pacing, movements, adjusting your position, checking your blood pressure. And the other thing I would be looking for is the progress of the dilation of the cervix. So because once you're in active labor, I'm expecting the cervix to continue to open due to the nature of the muscular contractions pulling up and opening the cervix, as well as the downward pressure of the fundus of the uterus nudging the baby further down. And when the baby is pushing on the cervix, so they're lucky I always have a baby right next to me. If that was my cervix and it was like 5 centimeters, okay, and my baby's head is pushing on it, and bear in mind that I want my baby's head nicely tucked in so that the round part is pushing, that downward pressure would cause it to open more. Okay, so we want what we call being well applied. If the baby's head is well applied to the cervix, it causes more downward pressure and it opens more effectively. Now, that's the reason why you sometimes hear in a hospital that they will break your bag of water, and why it goes faster when we break the water. And the reason for that is if my cervix is here and the bag of water is intact, then there's like a bulge of water between the baby's head and the cervix, isn't there? And that bulge of water is like a cushioning effect. So the bulge of water and the pressure of the baby's head is displacing the water, but it doesn't cause as much pressure on the cervix. If I break the bag of water, now the water goes away, the head comes down, and now it's directly on the cervix, and obviously that causes more pressure and it causes it to open faster. Does that make sense?
Yeah.
So you haven't got the bag of water there.
So it should be broken. That is correct then?
No, it's neither here nor there. It depends really on okay, so
are you saying it's better to have the water there so that when the head does get to the cervix, it like immediately just starts to open? Is that the point?
No, the point I was explaining why they sometimes do it in hospital to make it go faster. Okay,
instead of it happening just
yeah. And it's not that it doesn't open when it's still there and the head's up here. What actually happens is that the bag bulges out the cervix. Okay. So I might do an internal examination when you're having a contraction. And what I feel is this bulging bag of membranes out. And that's not a bad thing. It means that there's good downward pressure. So I personally, as a midwife and as a more conservative midwife, I won't break the bag of waters unless I would like to see the color of the water, because I suspect that there might be some fetal distress. Okay, so that would be the reason that I would consider breaking the bag of water. But if I've listened to the baby's heartbeats and I don't find any sign of distress, then I would prefer to leave the water bag intact and allow it to break spontaneously when it's ready. And the reason for that is because although it does go quicker because the head is directly on the cervix, it also means that you experience it a lot more intensely. So the sensation changes for you when the water's broken. Now, if it breaks spontaneously, that's great. It means it was meant to break, and I'm going to guide you and assist you and work with you to get to that point. Oh, okay, it's a little bit more intense. It feels different, but I can do this. But if I'm doing it just to speed things up, then I need to let you know, and I'm letting you know now. So if you're in the hospital and they offer that, you want to do that same conversation that you have with any intervention that's offered with you. Why do you want to break the bag of waters? Do you need to do it now? Is there a reason for it? And if you're just doing it to speed things up, is there a reason you want to speed things up? Now, I know for you, you might think, yes, I want to get it over and done with. But remember, if it speeds things up, it's also a little bit more intense. So as long as you're ready for that, then yes, go for it. And sometimes it is about the position. So it's a conversation that needs to be had. It's not that you're saying, I don't want it to be done, but you just want to make sure that doing it is going to guide, there's a reason for it, that they either want to check that there's, or rule out any fetal distress, or they're saying the baby's in not a great position, and if I break the bag of water, it might bring the baby's head down a little bit, and it will help the dilation and get things going. And maybe that is the right thing for you. Okay, but just ask the questions, because it's an intervention, and any intervention that we do naturally leads to other interventions. And specifically in hospital, where they do break the waters as a way of speeding things up, because they're on the clock and because they want everything to be done within 8 hours, if it doesn't speed up as expected, the next intervention would be giving you syntocinon, which once again increases the contractions and is a lot more intense for you. And if that doesn't work, then they consider a cesarean, because they're saying you're not progressing. Okay, they've done 2 interventions. Both of them should have made you go faster, and you haven't. So something's not working, and now we need to give you a cesarean. Okay, so it might be the right thing. I'm not saying it's wrong, but ask the questions and ask why they're doing it. Okay, is this right for you? Does that feel okay? All right.
Can I ask?
Yes.
What does the color of the water tell you?
So normally the color of the water is clear. And like if it broke, if your water broke, normally I'd expect it to be a clear, like almost wee in a way. But if the baby poos in the water, then it would be brown or green. And that could be a sign of fetal distress. Okay. Now, it's a big thing, and you read about it. It's what we call meconium stained glycol, because meconium is the baby's first poo. And if that baby poos in the water, but if a baby is post-dates, very often they do poo in the water. So in other words, if they're after 42 weeks, it's just like they can't hold it in anymore. So they poo in the water. And then the second thing is, and this is where a midwife's experience comes in, is that we very often see meconium in the water. And we never like seeing meconium in the water, but with experience, we also know we've got on the color of it and the consistency. So very often I'll break the water and I can see that it's slightly stained with meconium, but depending on how far you are in your labor, how your contractions are going, how you've progressed, I always look retrospectively, what's happened until this point. Is everything going well here? If you're towards the end and there's no fetal distress, I probably wouldn't be concerned. However, if there was what we call thick meconium, and you were only 4 centimeters dilated, I would transfer you. If there was thick meconium and the baby was about to be born, I would call the doctor and call the ambulance, but I would still continue to get the baby to be born while you're there, but the ambulance would be on standby so that if any complications during the birth, that we can transfer the baby afterwards. Because one of the things when there's meconium is we don't want the baby to aspirate the meconium. Now that's the reason, one of the things of equipment that we carry with us and that we have in the birth center and everywhere is a little suction apparatus. And we make sure that when baby is born, we just suction away any fluid. Actually, it doesn't necessarily have to be meconium, but any fluid we suction out of the mouth and the nose. But obviously it's the thick meconium particularly that we don't want the baby to inhale and for that to go into their lungs, because that can cause infection. Now, when you hear something like that, it sounds quite scary and you think, well, that would be enough reason for me. But remember that that's kind of like, it's one of those things that can happen in hospital as well, okay? And it's very much up to the care provider as to how they manage that. And, you know, that's part of how the baby is born. Okay. So I veered off a little bit, but I think the most important thing about being in the hospital is that we monitor, or in the birth center or at home, is that I'm constantly monitoring your progress. And I'm expecting you, because the nature of labor is dynamic, I expect that every 4 hours, there needs to be some change. And if at any stage there isn't a change, what is going on? What can I do? And that would be the difference as well at a home birth and a birth center, is that if I see that there's a stall or the labor is slowing or not going as expected, I wouldn't immediately transfer you if you were still doing okay and your baby was still doing okay, but I would consider getting you to get up and get moving, or to change position, or to do some spinning babies movements to create space. Where is this baby at the moment? And when I talk about where the baby is, just hang on, I need to get my pelvis. This is the inlet of the pelvis, and that's the outlet. So I want to know if my baby's in the inlet, the mid pelvis, or the outlet, because baby can get stuck at any of the point, not stuck, but slowed at any of these stages in the inlet, the mid pelvis, or the outlet. And different positions will create space in different parts of your pelvis. So I would guide you to do those different positions during your labor to create space and help baby to move. And you'll notice that, like if you move into a certain position and you just feel it's like such a relief if you like lean forward or take your leg out to the side or do a deep lunge, what you're doing then is you're creating space, because your baby is navigating and they enter the pelvis facing your back, but then they turn to the side, their head, little head turns to the side because there's more space like that, okay? And then they're rotating all the way down to come in. Sorry, what I actually meant is that they come in at the side and turn to face your back. So it's come in sideways, turn to face your back, and then navigate their way through so that they can slide all the way along here, okay? Now, at any stage in this process, you want to be able to be creating space over here in the outlet. And the positions that are going to create space in the outlets are your wide leg, child's pose, or a lunge, or being on the bed with one leg out to the side. So if you had one leg out to the side, you would possibly just, I'm exaggerating, but if you put one leg out to the side, you'd be creating space here, okay, or the other way around. Went into a wide leg child's pose, you're creating space on both sides in that outlet, okay? So those would be the things that I would be guiding you to do. In a home birth situation as well, I'd probably have the use of a birth pool. And what helps with it being in a birth pool is that you've got a lot more freedom of movement. You can easily kind of shift from leaning on your knees to leaning back to going side to side. You get the weight of your belly off. The movement of the water and the warmth of the water also provide a lot of comfort and relief. It just feels really, really good in the warm water. Or if you were at home before you went into the hospital, you could also be using that. And, you know, you saw at Alnisa, we've got one of those as well, but the water definitely does help with that. So let me just see what other questions I had here. God, my whole thing goes dead and black. While I'm looking for that next question, do you want to just think if you've got any questions about what I've talked about so far?
Going back to the baby's position, if it's in breech, at how many weeks would you say that changes from a low risk pregnancy?
Because it's in breech.
Yes.
So I'd like your baby to have changed out of breech by 36 weeks, but 36 weeks isn't too late to still try and move your baby into a head down position. So there's something called an external cephalic version where they manually take the head and the bum and they sort of move it around, but they would generally do it in the ultrasonographer's room, so with an ultrasound, so they can see the position of the placenta and make sure that it's doing it. So it would usually be done by your obstetrician. Things that I would do to help you would be like rebozo sifting, and I would send you for acupuncture and moxibustion and massage, and I would do some hypnosis with you. I've had very, 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 very successful babies turn with hypnosis. Literally in the session. So, you know, I would try all of those things, but I also encourage you. I mean, I just kind of believe that some babies are meant to be in the bum down position. That's just the way they are. And if you try all of those things and at 37 weeks, they still haven't changed, 38 weeks, they still haven't, you keep doing, you get to 40 weeks and they haven't changed, then that just is the way that it is. And depending on what your care provider, what their preferences or what their skill level is or what they say, it may mean that you have to have a cesarean section. And then I don't know how you feel about that, but it might be okay for you, you know, it might be the way your baby wants to be born. I'm not sure. Is your baby breech?
Yes, I've been told every visit that my baby's in breech position.
But you're only 24 weeks.
26 weeks.
Oh, that's okay. You've still got
But
plenty of time.
Yeah, I thought it was normal for them to be in breech and then they turn at the end of the pregnancy.
Yeah, I'm sure it'll turn the next couple of weeks. The only thing I would encourage you to do now, while you're waiting for the baby to turn, is to continue to visualize your baby in the head down position. But just because it's been breech every time you've had a visit doesn't mean it's breech between the visits.
Mm.
You know, your baby's tumbling around and moving all the time at this stage. I mean, he's tiny and there's lots of room in there. So it's very, 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 very high chance that it will have turned. Remember that by the time it gets to 36 weeks, there's not that much room to move. So if they're head down by 36 weeks, then the chances of moving to breech are very unlikely. Not impossible, but highly unlikely. So because that's when baby starts now moving down further and getting ready to go in and enter. So they start engaging. But I mean, your baby's very tiny at the moment. So there is lots of time for your baby to move. Okay. Any other questions about any of those other things?
When you mentioned normally you have 24 hours to be in labor, but not in a private hospital. What is it like in a private hospital?
Well, you know, if you had to go into a private hospital and you were in early labor, so as in you're not sure if you're in labor and you just having a couple of Braxton Hicks and they do an internal examination and you may be 1 or 2 centimeters, they may send you home, but they may not. If they don't, they're not going to necessarily give you those 24 hours because they also, for them, time is money. They want you in and out there within two days. So they don't want you hanging about in early labor for 2 days. So, you know, if they do a CTG and they see, oh, you're in early labor, you know, you're having contractions, they're quite irregular, they're quite mild, but hey, you're in hospital, I can give you Syntocinon. So I'm going to hook you up to an IV and I'm going to start some Syntocinon and we're going to get those contractions going. And that's exactly what happened. 6 hours later, that Syntocinon is doing its thing. You're having good, strong contractions. But now, because they're pretty intense and because it sort of happened quite unnaturally, because it's been stimulated, you know, natural contractions will gradually increase in intensity and frequency. But a contraction that's brought on by Syntocinon, I give you a drip and I start by 3 mils an hour. 30 minutes later, I double that to 6, 30 minutes later, 12. So I keep on bumping it up until I get the desired effect. So also the sensation you experience with a chemically induced contraction is different to the sensation you experience with a naturally induced contraction, only because the oxytocin that causes your natural contractions crosses the blood-brain barrier and causes a release of endorphins that guide and assist you with the pain and altered state of consciousness. But the synthetic oxytocin or Syntocinon doesn't cross the blood-brain barrier, so you don't get that same endorphin natural pain relieving effect. So you definitely experience the contractions differently. However, you've never been in labor before, so actually you've got nothing to compare it with. You just know that it's a little bit more intense. But I think the point I'm trying to make is that if we chemically induce your contractions, they're going to try and get an effect within 6 hours, and they will push hard to get that effect, which can cause fetal distress because they're pushing so hard. Or if they don't get the desired effect within 6 to 8 to 12 hours, in other words, if your body doesn't respond, then it will be classified as a failed induction, and then the next step would be a cesarean.
Okay.
Or
that sounds so intense. It sounds like you are just being moved through all of these stages. Like, is it ever turn out positive for the
it does. It does. I mean, I don't know if I'm giving you worst case scenario, but I am telling you what generally happens in a hospital situation. And I know that is from direct experience, you know. I think, and the reason I'm sharing it with you is more to be aware. I really don't want to scare you or make you think that it's bad, but that is the reality of private healthcare, is that it is moving through the system.
Yeah.
It is a little bit, you know, because if the way they see it is, if you're in labor, then you've come in to have your baby and let's get this baby out. You know, it's not, you know, for me as a midwife in a home birth or birth center, I've got a window, and I know if that baby isn't born by the time I go home at 7 o'clock that evening, or if it's a home birth and the baby's not born, I'm in for the long haul. You know, I'm not trying to rush things along. I mean, if it does go on for more than 24 hours or whatever, I call in a backup or I sleep or whatever, but I'm not trying to get it out, because I'm also valuing the experience. But in a hospital, it's not that much about the experience, really.
That was nice to hear. Yeah, valuing that experience. Like, that's what I was saying earlier. You get that, it's like that one-time thing that you get to experience together by having a birth at home or being in the birth center. You get to experience that together.
You can get that in the hospital. Okay? You can. I think you just have to work a little bit harder for it. And I think you need to be a little bit more aware and unfortunately question it, but question it in a way that you would with anything that was being done to you. So, you know, any intervention that's offered, just like ask, why are you offering this intervention? But I think that the other points I'm trying to make is that don't go in too early. If you go in when you are already in established active labor, you've probably doubled your chances of having a positive birth experience and minimizing interventions. For that reason, because if you're there too early and nothing is happening, they want to give you something to make it happen. Otherwise, why are you here?
Yeah.
Okay. But if it's already happening and you're already in good, strong labor and you get to hospital, then there's nothing for them to do. It's just like, oh, great, she's in labor. She's 5 centimeters, halfway through, great contractions, managing well. Let's just keep going, because now we're already on that trajectory. Let's just keep on going with that. And I'd say that that would be a good reason to have a doula. Okay, because that is one of the things that a doula will do for you, is that she will be with you in early labor at home, and she will guide and assist you to not go into the hospital too soon. Now, she can't do internal examinations, and depending on her level of experience and her age and all sorts of things, you know, will depend on how much she can guide and assist. But you know, there's other ways as well, like with, you know, that chiropractor, Dr. Megan Hope, who talked at the summit. So I went over, she had Charlene as her doula, and then I came in when she was in active labor, and I spent another 2 or 3 hours with her at home. And then I did an examination. I said, all right, you're like over 6 centimeters, time to go. Like, when you want to go, you can go. You don't have to go now, but when you're ready. And I knew she was more or less ready anyway. And that was when she went in. And then she was only in the hospital for another 3 hours, and her baby was born. So she cut down
that story. I love, like, that sounds like a path I feel comfortable, because I'm getting my home experience. I'm getting the support from both, like having you, having my team there, having a doula, and then being able to go off to hospital and be like, cool, now we can finish it off, you know. That seems, it all fits in my brain. Like, I like that whole process.
I think it's very empowering, you know, because you very much you've done
most of it.
Exactly, you have done most of it. You really have done most of it. By the time you get there, it's just like, okay, now I'm ready to have my baby, and I'm having it in the hospital because I feel safe there. My doctor's there, everything I need is there, but I'm in my zone and I'm doing this.
Okay. I like
it. Right, now I just want to talk a little bit more about complications, because I've kind of covered the whole labor thing. And like I say, I'm on high alert throughout your labor. Even though I'm cool as a cucumber, I'm definitely watching, I'm listening, I'm smelling, all my senses are on high alert as well, because that's what I'm gathering a lot of information. And I can make that decision to transfer you at any stage during your labor. Obviously, we don't want to, but my philosophy is I would rather transfer you too early than too late. It's always done in conversation with you. So tell you what's happening, you know, things aren't progressing as expected here, or I've broken your waters, the color is not the color that I would like it to be, and you're only so far, and I really think that we need to transfer you. Now, if I'm working at Alnisa, this is just one of my little inside tricks here. Sometimes we've got very specific guidelines of when we need to transfer. And so sometimes I will get to that point where now, according to the guidelines, I need to call the Mowbray and do what we call give a report on what's happening. And they will say, okay, thank you for letting us know. If nothing has happened in the next 6 hours, then you need to transfer, or call the, and we've got different levels of ambulance, and they'll say call the government ambulance because they know that it'll take 12 hours. And then they say, you know, if by the time the ambulance comes, she hasn't given birth or whatever. So then I know that I've got another 6 hours, and that ambulance might be there tomorrow. And then by the baby's born 6 hours later, and I cancel the ambulance. But if it's something a little bit more urgent, I will report that in, and then they will say, no, this needs to happen. And then they call the flying squad, or I call in a private ambulance. And then I know the private ambulance will be there in 10 minutes. Okay. And once that ambulance is there, it's a very quick transfer over, hand over to the paramedics, file is handed over, and she will go off to Mowbray. Now, if I'm doing a home birth, it depends on who my backup is as to where she will go, whether that's to Mowbray or to a private hospital. Obviously, in Cape Town now, we are very much with our hands tied. None of the private hospitals, you know, we find it very difficult to get backup from the private hospitals. But it just depends. That is how it would work traditionally, is that we would phone your backup doctor, give them what is happening. They would say, right, you need to bring her in. And as a home birth midwife, for me, it's very important that I also, because I've got a relationship with my backup doctor, I'm not going to wait until it's too late and he has to now pick up the pieces. I'm going to call it earlier and say, I'm bringing her in. I still think things are going to happen, but it's not looking like it is at the moment. So we're moving her into hospital, and then I'm going to carry on in hospital. And if it doesn't happen from there, then you can come in, but she's already there. So that would be how it would traditionally work with your private backup gynae, as opposed to coming in, he comes in and immediately has to do a cesarean because he doesn't, he hasn't really got all the full background and history and all of that. So it really does depend, if you're having a home birth, on the relationship, who your backup is, and the relationship that the midwife has with the backup, and the arrangement that they have with that backup gynae and with the hospital that you're going to. Because, before we used to be able to go in and actually do it in the hospital. So you'd have your own midwife, but in the hospital, which is another ideal situation, but that's also not possible anymore. So those are the complications, and most complications would just require a transfer to hospital, because it just means that it's now going out of my scope of practice. My scope of practice is low risk pregnancy, low risk birth, where I can manage the normal complications that might happen, and the normal complications that might happen that I don't want to happen, but that I can manage would be, a baby, sometimes their shoulders get stuck, then I know how to manage that. Or maybe that the baby needs some resuscitation or help after birth. I have the equipment, I have the skills, I have the training to be able to manage that. If you have a lot of bleeding, or what we call a postpartum hemorrhage after birth, it's a common complication of pregnancy and birth. It can happen whether you're at home, in a field, at hospital, whatever. I have the training and the drugs and the skill to be able to manage that. So those are the things. I carry resuscitation equipment, I carry the drugs to be able to manage a postpartum hemorrhage, and I have the skill to be able to manage a baby that isn't coming down, that is slightly stuck, to help you to maneuver that baby out. And if you do tear, or I need to do an episiotomy, which I don't do routinely, hardly ever, I have suturing material and I will do the suturing as well. So we have those skills. Those are very common complications, and whether they happen at home or at hospital, I'm going to deal with them in exactly the same way. You saw that video at Al-Nisa. The only thing that I don't have is that little Neopuff thing. It's just a fancy version of the manual one that I have. Actually, I've got a picture of my birth bag here. I'm going to show that to you. My screen went a bit messy here, but then I'll answer the question about how isn't home birth messy and how sterile it is. So that's pretty much what my home birth kit looks like. You can see over here, this is my handheld Doppler and my KY jelly. So I'm listening to the baby's heartbeat every half an hour. I'm checking your blood pressure every half an hour to 1 hour. These are my instruments that I use to clamp and cut the cord. This is my little baby ambu bag, that if I have to do any resuscitation, that I've got that. That's my oxygen tubing. There's a hole underneath here, is all sorts of disposable pads and some suture material and a suture pack. But this is and all my homeopathics here. But that is basically the main stuff that I carry in my birth kit. As I say, when I'm at Al-Nisa, it's the same thing. It's just spread out in a big room.
And the homeopathic stuff that you had there, is that like the essential oil and things? Like I remember one of the ladies was talking about how you can use the oils to calm or progress, or is it those
all of those things,
smells? Okay.
Yeah, so homeopathic little druggies under the tongue, and the essential oils, all of those things that I carry. I don't use those at Al-Nisa though, just because, I just don't. Because, when I have a very different relationship with my private clients. So this is just like a little list of all the things that I have, my emergency medications. So that would be Syntocinon for any hemorrhaging. my Doppler, listen to, monitor the baby, my sterile instruments. I do carry vitamin K. I don't carry eye ointments. And not all moms want to have vitamin K. In Alnisa, I have to give vitamin K and I have to give eye ointment. Suction device, oxygen
the mother,
tank,
the baby?
the baby.
Sorry,
Sorry. All babies have a vitamin K injection after birth. 1 in 1,000 babies isn't born with enough. It's a clotting factor, so it just helps the blood to clot. So generally, all babies will have a vitamin K injection after birth. I can share some information about that with you, just the pros and cons, but it's a very standard, acceptable practice. And
an eye ointment?
The eye ointment is also to prevent any eye infections, and also standard practice. It's just chloromycetin. It's like an antibiotic eye ointment. And that's also given standard practice in hospital births and in birth centers. At home birth, I think the difference at a home birth is that parents are a lot more informed. So we have that discussion. If they say they don't want it, then I honor that. It's their choice. We go through the pros, cons, all of that. But in a hospital and birth center, it's generally just the standard care that they get.
And if the infant does end up having an eye infection and say you didn't want to have it, can it be?
It can be treated. No, it can be treated. And I think it's also if mom's got herpes, then we need to be more mindful of that, especially if it's active herpes and specifically active syphilis, although active syphilis is a contraindication for vaginal birth anyway. Okay. Yeah, and just all of those things. So those are all the things that I carry on my home birth kit. And right. Isn't a home birth messy, and how sterile is it?
This is like my big concern. The things I hear about, you need this other bed sheet and you're going to give birth in your bed, and I think, but now you want to sleep there.
Yeah, so I generally get moms to buy a shower curtain or 2 shower curtains, and just put that under their sheets, if they end up giving birth in the bed, which at a home birth they usually don't, they're on the floor in the bathroom or the kitchen or something. And generally not where they've set everything up for whatever reason. But I just run around after them with a little linen saver. It really is only after the birth or during the birth that it tends to be quite messy. And yes, there is a significant amount of blood loss with the birth. Okay, so you can expect up to 300 mils, which is it's a fair amount of blood. And it always looks worse, especially if it does spread out on a white sheet. I mean, it looks like you slaughtered a cow, but it's just it would be normal and expected. Okay. And we do. So if you've got all the old towels and the sheets and the plastic things, it's easy to roll up and throw it away or whatever. In terms of being sterile, well, birth isn't really a sterile procedure. And actually, that's one of the beautiful things about doing a home birth, is that you are in your environment where you've got, you are colonized to everything. It's your normal stuff, you've got your dogs and stuff. I mean, that's your environment. You're not going to go and clean up all the stuff. I mean, you don't necessarily want dog hair, but I mean, still, it is your dog stuff. And it is important that the baby is born into that, so that it is colonized with that. I mean, we talk about the microbiome and the importance of a vaginal birth for the baby to pass through the vagina and get colonized and exposed to the normal vaginal flora. And that is allowed to happen in a place that is not overly sterile. So it's not to say that I don't use sterile gloves and I don't give you a clean and whatever, but I'm not, in the hospital, we're gowning and gloving and long jackets, and especially in the movies, you see them all like they're going to do a cesarean. That's a sterile procedure. It's really important that you are sterile and covered up. But in a normal birth, it's not sterile. And it shouldn't be sterile. Even we talk about, especially in a water birth, sometimes in the process of the baby's head crowning, some mom will pass a stool, and that's okay, because the stool itself is also part of that microbiome and that the colonization of the baby. So I'm not necessarily going to leave it floating in the pool. I will sort of fish it out and dispose.
It's also making the space, isn't it? Because I mean, you're pushing and everything like that.
Totally.
It's part of.
Yeah, totally. Yeah, totally. So yes, I'll take it out the water, but it doesn't mean that water is now dirty. It's actually perfect for the baby to be born into that, because it is colonizing the baby. So yeah, we manage the mess. It's really not that bad, especially a water birth. You know, the birth pool itself has got that plastic liner. So once you finish with the birth, it's you know, it's bloody water, but we put the hose in, reverse it out. It goes out the window, waters the garden. Once you've emptied that pool out, you just take that liner, wrap it up, and throw the whole thing away, and then just let the pool down, and you're done. Yeah. So it's not as messy as one would expect. What other questions did we have here? Oh, pain control at a home birth. So generally at a home birth specifically, I have to be honest that the majority of women who have a home birth don't require pain control or pain medication, and don't request it, and they are so mentally, physically, and emotionally prepared that it doesn't even enter their mind. If it does, it usually means something is going not the way I should. It's usually when they start like seeming like they need it, that's already for me a flag that something's not going the way that it should. She's not progressing the way she should, and we're probably going to end up transferring, even if I am just transferring her for pain medication. You know, and to whether that's for an epidural, because I don't carry pethidine either. So pethidine is a Schedule 5 drug that we use, and I do have it at Alnisa, and I'm able to use it at Alnisa, but I'm not able to carry it in my home birth kit, so I don't have it. So the only thing I have, actually I don't have anything for pain when I'm doing a home birth, except breathing and my voice and hypnobirthing and everything else. In Alnisa, we have Gasone or Internox and pethidine, but not epidural. So the only, you know, in hospital, you have all of that, plus an epidural. But a home birth environment is so conducive to birth that really the majority of women don't. It's just so much more calm. There's no...
At your own time and pace,
yeah,
right?
There's no rush and there's no pressure and whatever. So as things ramp up, you know, everyone steps in and they're there to support, and it just kind of goes. So, and then you were saying, what about the noise? So I've been at some pretty loud births, and I used to work at a home. There's a midwife in Somerset West that I used to work a lot with, and she has a birth room at her home, which is in a suburban area. And, you know, very often there was, you know, birth can be quite loud, but either the neighbors were used to it or they never, ever said anything, you know. It's probably the same as having loud sex, I'd say.
Yeah.
If your neighbors ever complain about that, then
yeah, why are you listening?
Having sex. So, and the noises are much the same, I got to say.
Yeah, I suppose it's wanting to have that relief, and then when you find it, that's yeah, I can understand.
Yeah. Noisy and making noise in labor is good, hey? If it feels good for you. Some women do, some women don't, but it's not a bad thing. But it does help you to vocalize and keep the throat nice and soft and open, and if I'm loose.
Yeah, that I can understand, but like the whole shouting and stuff like that, well, I suppose it depends.
Yeah, no, shouting can be counter. Yeah. It can be. It depends when it's happening.
Yeah, and you need to be feeling the moment and what you're going through.
Yeah.
Sounds so simple now.
You two are still so early and you're learning so much. You're going to be pros by the time you get there.
Yeah, I hope so.
Pros.
Yeah, it's very cool.
Any other questions? I don't know if we've covered everything. I know we talked about pain control, we talked about it being messy, talked about it, the equipment, pain control, what kind of prenatal care do you receive when you plan for home birth? I think I've spoke about that already.
Isn't it post?
No, I spoke about it.
Oh, prenatal is when you come and you do the visits and everything.
Exactly.
Does that mean that you have to go back to the gynae for the scans and stuff, or does that mean you? Okay, so you continue that and still see you as well.
Yes. So as a home birth midwife, I tend to do the same visiting schedule as your gynae. So every 4 weeks until 28 weeks, every 2 weeks till 36, and every week until 40. But you still see your gynae once or twice during that. Okay. So 2 of those visits will be replaced by your gynae. And all your ultrasounds would be in addition to those visits.
Okay.
Okay.
And then the postnatal care?
Postnatal care is much better, because I would usually see you day 1, 3, 5, 10, and then at 6 weeks.
Okay.
Yeah, so postnatal care is great. And that's when you really, really need it as well, because I think with the hospital birth, you will be discharged on day 2 or 3, and that's really when the wheels fall off, because your milk comes in, baby wakes up, and the enormity of taking a baby home hits a twang, your hormone levels.
Shame, y'all. Got to get in the car, the death machine, and all these crazy people driving around me.
What do you check in the postnatal care?
So I would come, and it's a combination of checking you and your baby. When I'm checking you, I'm checking your blood pressure. I'm checking, I feel your tummy to feel that your uterus is going back to its normal size and it's nicely contracted. I'm checking the amount and the color of your bleeding. I expect it to get less and less every visit, and to change color from bright red to brown to pink to nothing. I'm making sure there's no signs of infection. If you've had a tear or a cut, I'm checking on your sutures. I'm checking to see if your ankles are swollen and how you're managing that. I'm checking if you're getting enough sleep, if you're getting enough to eat, how your breast milk is coming in, health of your nipples, the latch of your baby. I'm going to weigh your baby, check the baby's color, if there's any jaundice, and sit with you and watch a full feed and guide you literally day by day, because the breastfeeding in the first 6 weeks particularly, but the first 10 days, every single day is different. And it's really important that you get the right advice on each day, so that you don't jump ahead. And so you don't jump ahead, basically. You've got to stay in the moment. That'll be the biggest lesson your baby teaches you, is stay in the moment. So particularly with breastfeeding, you've got to really do that, so that we can deal with each issue as it arises. And there will be many, but we deal with each one as it arises, because I know what to expect and I know which ones are going to come and how they're going to come. And then we get over them. And by 6 weeks, you'll be in a routine. Breast milk is established. You understand your baby's sleep, and all is well in your world.
Okay.
Just a question with the bleeding. How long do you bleed for normally?
So normally for up to 6 weeks, but usually by the end of 2 or 3 weeks, it has subsided. So it starts off as a heavy period, and it becomes like a moderate. And by the end of 2 weeks, it's usually like a light period. And you can spot on and off for up to 6 weeks. And for the first few days, you can expect quite big clots to come out. But you'd be looking for lots of clots, and a bad smell or a temperature would be an indication that possibly some of the placenta or the membranes have stayed behind, and it would cause a very bad infection. So that would be another thing that I'd be checking, but you would notice it as well, because you'd be having a lot of pain, a lot of bleeding, and a bad smell and fever. Do you feel a little bit more comfortable about understanding the need for transfer, though, and the amounts of time that we have in that whole, that it's not just I'm having a baby and it's going to happen in 1 or 2 hours, and what if something goes wrong? Like there's really a big buildup, and it's many, many hours, and at any stage in those many hours, a decision could be made that this is not progressing as expected, and we need to manage it in a more
But if you do have the transfer, then does that mean that you would stop doing like the home birthing that you're doing, or would that be then moved into a hospital environment? And like, or does it immediately go as soon as you leave home and you're in a hospital environment, now you start with the whole, this is the hospital care, like the induction and the this and the, whatever it is they want to give you? Does it have to go that route?
It doesn't have to. It would depend very much on when you were transferred, like how far you were in your labor.
Oh, right. Okay.
And why you were transferred. Okay. As to, I mean, if you have been transferred, then there's probably there's probably a need for some intervention of sorts. So I would expect that they would be doing an intervention. Otherwise, I would have kept you at home.
But then would because I wouldn't want to lose the support. So like the support that I've had at home and the whole process, would that support then stop when you get to the hospital? Or do you still, like, are you there, or is it just dependent on the situation?
It's dependent on the doctor more than anything else. Yeah, like before, I would have been there and I would have continued. I would have handed over, and the staff, hospital staff, midwives would have possibly taken over your care. But I would still be there, or I could be your continue to be your primary midwife in conjunction with your doctor or partnership with your doctor. But I think these days it would be more like handing over to the staff midwife, and I would probably then have to, if it was me, I'd have to then either step back and just be your doula, or I wouldn't be allowed in at all. I don't know. You know, we haven't been allowed in for a while now, and I've essentially stepped away just because it's really difficult for me to have to navigate that. So I think it would really just depend on the doctor as well. I mean, I've had some really great experiences with some of the doctors, but it's hard to say. And with COVID, it's also difficult, you know. It might even be that they let me in, but then it's COVID, and then you're not allowed in.
Yeah.